Hi, Dr. Garima here. I'm back. What are we going to do today? We are going to discuss further ethical questions. Question number 12, 13, and 14 from the book. Which book? The comprehensive ADC book, which I have made, published last month. And it includes scenario based questions or single best questions from Odell, therapeutic guidelines, infection control, ethics, consent, COVID 19 and public health dentistry, all of which are from the ADC resource book list. So basically a question bank from these books basically. Another book is in still making, which belongs to all the subjects of dentistry. It's going to be a big book, more than 1000 MCQs, SBQs rather, but I still have to publish it. So anyways, let's jump on to these questions. The ethics question, because there is no particular textbook and like I mentioned, no session is conducted in your graduate dentistry which teaches you what is ethics, how you are supposed to incorporate that in your practice with the patients, with your colleagues, with your staff, and how to handle the complications or situations that may arise. You're just expected to know them, which is not fair. But it is very much a part of your professional dentistry. As much as important is the work that you do, it is important how you communicate in a professional manner with the patient, maintaining a certain standard of ethics which should never be violated. As much as you can be fined or your license can be cancelled or a malpractice can be put on you for a work that is done wrong, a dental work that is done wrong, the same amount of fine can be imposed on you if you don't follow ethics, even though you may have done the best possible perfect work in the world, So ethics is equally important as much as your work. And though ethics does not require to be learned 5 years, which you do for your dental subjects, I think a 2-hour session on ethics is enough, but even that is never conducted. So anyways, ADC resource has mentioned ethical certain articles and they themselves have published that on their website, but it's just information. I have met questions on that information because similar questions are asked in the exam and hence we are solving that. So this is a very important video, as in the ethical videos, all of the ones which I'm been shooting, because it won't just help you in the exam, it would help you in your practical life as well. And that will just uplift your practice to another level. So anyways, let's just go ahead. So I have finished discussing, I think, 11 questions so far. Today we are going to discuss further 3 questions. What must be present for consent to be considered valid? Now, example, you have a patient who's come for an extraction. Now, you of course talk verbally to the patient and tell them, you know what, this is the extraction, these are the risks, these are the consequences, these are the after treatment modalities. And the patient says, yes, doctor, go ahead. This is a verbal consent. But it's just verbal between you and the patient and your assistant which was there. There has to be a written documentation which mentions exactly what you have said. And the patient has to read that and the patient has to understand that. And you have to make sure that the patient has a decision-making ability and that he has understood what you have spoken, and then in that conscious decision-making ability, he's signing that consent. Only then the consent is considered valid. Suppose there is a patient from another language. You speak English and for example the other patient is speaking, say, Arabic. And somehow in Google Translation you manage to tell them the basic steps of extraction and the patient agrees. But when you give him a form to sign, it's written in English. And there are many more risks and consequences that you have mentioned in detail, but due to the limited amount of time and knowing your skill that you'll be able to manage that either way, you didn't go deep dive down into the complications that's mentioned on the paper, but you have given that paper to sign to that patient who cannot read English. So though that patient has a decision-making capacity, he's not read the document because it's in another language. Would that consent be considered valid even if he has signed on it? And if something were to happen and he goes and raises a complaint, no, that consent will not be considered valid, even though you may have verbally said something right. Because when the governing bodies will ask the patient, did you understand that consent form that you have signed? And the patient says no, that consent becomes invalid. You understand my point? So you can always, Google is so amazing. You can just translate your entire written stuff into the language that the patient understands, and then print out that and then ask the patient to sign it. You understand? So I always do that. Like whenever I have many Russian speaking patients and Chinese speaking and Korean speaking and Japanese speaking. Dubai is a multinational country. So when they come, they barely can speak a word of English. I just go on Google, I start translating. They understand. Yes, it does take me a little more time because then I list down exactly what all I have to say, which is there in my consent form. And I ask them to read it. Once they have read everything, I copy paste the translated version, which is in their language. You understand? Google has both English and say I'm translating it to Chinese. Then I'll copy paste that Chinese thing into the notes of the patients in my system. I will printing that out and I'll be taking the signature of that patient and I'll be putting that in my consent form. You get my point? So that is a valid consent. So that is a little time consuming, yes, but then that's the right way to go. So now coming back to the question, what must be present for consent to be considered valid? Consent must be verbal only. I mean, verbal consent has to be taken, but it cannot be just verbal. Patient must sign a form without explanation. Ooh, no. Would you like to sign a form without any explanation? It must be informed, voluntary, and competent. Yes, it has to be informed. You have to inform the patient. Voluntary means the patient has to independently, voluntarily agree for it. You cannot keep the patient on a gunpoint, right? Sign. No, you can't. And competent. Competent is what I mean by the decision-making capacity. The patient should be in his conscious state of mind and very aware of what you have just spoken. The patient, like for example, I mean, I've not encountered any patient who is, say, a drug addict or has come intoxicated or a senile patient. Senile means a very old patient who's not like well and is not like completely aware of the situation and is dependent on a legal guardian to make a decision. So in that scenario, even though the patient may be that old patient, but because he doesn't look well, but the treatment has to be done, then he's not competent to give the decision. The legal guardian has to give for him. You get my point? That is the meaning of the word competent. The patient has to be very conscious, aware, and should be of decision-making capacity. That is the right answer, by the way, for this question. It must be in the presence of another dentist. No, you don't need another dentist and to make the patient sign on the form. So I hope you understand this question, and any questions that may be asked and related to the consent. Now you know I've given you the entire concept. Now, which situation demonstrates beneficence? What is beneficence in the first place in ethical dental terms? It means that acting in the patient's best interest, prioritizing care and well-being. I'll give you an example of today itself. I had a patient and he was 3.5 years old. Now he had a central incisor which was fused with a supernumerary tooth. Now it was a partial fusion, meaning there was a crack in between which got caries and the roots were fused. It was like a jumbo root of two teeth joint, and that root had a bit of an open apex. Now, I have treated such cases with root canals and with extractions. Now, this patient is very hyperactive, okay? He was very hyperactive. And normally, if a patient is very cooperative and at the age group of 4.5 or 5 and comes with this kind of scenario, I usually do a root canal. I give that option. Because the patient is cooperative, the patient is consciously aware of the smile, and I know I can fix that tooth with a root canal and let the tooth exfoliate when it has to. But in this particular patient, because he's so hyperactive, I don't want to put him under general anesthesia just for a single tooth. I have given the options to the parent that we can do a general anesthesia and do a root canal. That would save the tooth. But if you don't want to put the child under general anesthesia for one tooth, I can happily extract that tooth on the chair as well, because it's completely carious and it's breaking down and an abscess will form soon. So here, looking at the overall nature of the patient, how he's behaving, a root canal on the chair is not a possible option because he wouldn't even sit on the chair. I had to take an x-ray with him standing a little far away from the chair, and that too after like 10 minutes of coaxing him. No way such a child is going to sit on the chair, open his mouth, let me give him an injection and do a root canal. The mother herself said there is no way the child is going to sit. And I saw, like, that is not a possible good option. Putting the child under general anesthesia is an option, but it is really needed for the overall well-being of the child. I mean, just for one tooth. No, it doesn't make sense, right? So, looking at the overall picture and keeping the well-being of the patient in mind, the beneficial decision is to extract the tooth. You understand my point? So, the decision of the same condition of the tooth in any other patient would depend on the overall status of that patient. That is what beneficence means. It does not mean that you are keeping your costs or finances a priority over the treatment. No, you are keeping the patient's treatment in consideration with his overall structure, the emotional capacity of the patient. Finances come later on. You get my point? So, which situation demonstrates beneficence? Withholding pain relief to reduce cost? Ouch! No. Providing necessary care even if not financially beneficial? Yes. Refusing treatment due to appearance? No. Performing experimental procedures without approval? No. What does it mean, performing experimental procedures without approval? You have to take approval from either the insurance, if the patient has insurance, or from the patient. You cannot just experiment anything without approval. I would like to give you an example of option A also. Withholding pain relief to reduce cost. When I was practicing in Bombay, I had come across this few stories of few colleagues who were doing root canals in adult patients. And they said that many a times to make sure that the patient comes back to them when they start a root canal is that instead of cleaning all the 3 canals, say they are doing a molar, maxillary molar, they used to extirpate only 2 canals and leave the 3rd canal with the nerve inside. And they just put a medication in those 2 canals and let the 3rd one be like that, so that the patient still continues to have mild pain, not the severe pain that he had, and that he returns back for the 2nd session. If root canal cannot be finished in 1 session, I didn't say anything at that point of time, but it's cruel, But their strategy was, if we relieve the pain of the patient may not come back, and we have started the root canal, but we have not finished it yet, and we still have to give a, core and a crown, and the crown cost almost matches the root canal cost. We want the patient to come back, so this is what we do. What is this? This is withholding pain relief to reduce cost, right? Or to make more money, I would say. So, is this beneficence? No. They just invented this method to get the patient back to them. I don't agree with such methods, but a lot of people practice such a thing, which is not great. And I wouldn't say it's the dentist just to be blamed, it's the patients to be blamed as well if they resort to such strategies that, okay, my pain's gone, I'm not going to go back to the dentist. I would rather say let the dentist charge the full amount of the root canal in the first session itself and relieve the pain, do proper extirpation. Now it's up to the patient to come back or not. Anyways, you have charged him, right? So at least you are satisfied instead of resorting to such techniques that you open the tooth and you just leave 1 canal as it is. So don't do that. You get my point? So that's why that option is there. You must be wondering from where all these options came. These are actually practical life situation options. These things happen, and that is why those options are there. People are doing such things. You may think, what, this is like some hypothetical text written as an option. No, these things have actually happened. I have actually seen such things happening. What can you say? You can't do anything, but you can learn to do the right thing. Probably if such kind of ethics were taught in the graduate program, being imbibed to your head, you would know what is the right thing to do. Even if you saw somebody doing something wrong, you know what's right. Because you don't know the right ethics sometimes, you think whatever the other person is doing, which may be wrong, is the right thing. Get my point? So anyways, the answer is B. That's providing necessary care even if it's not financially beneficial. Many times, say we have insurance patients and they have, hopped on to 2-3 different clinics. They have exhausted their money, and then the child ends up with a swelling, and you're about to leave. Your time is getting finished, and then they call me, our child has a swelling, doctor, we have to come and visit you. Can you help? Fine, come. Now, there is a swelling. I know I have to drain that abscess. I don't know if the insurance is going to approve that or not. But do I wait for the insurance approval then? No, I let it go. I have to accept that as a part of me being a doctor and me being a healer. It's not always like I will get the money for which I'm going to work for. Service is main priority, but money comes secondary. Money is important, but it is not at the expense of the service. I don't work for money. I work for dentistry. Money comes because I'm doing a service, not the other way around. Okay? So when that thing is imbibed in me, I openly tell the patient, you know what, we'll apply for the insurance. If it comes, it comes. If it doesn't, we'll talk about it. But I'm not dealing this treatment and keeping your child in pain because your insurance approval is not going to come because the day is over. I take a consent. I explain them everything. And I right away go and start the treatment, at least to relieve the pain off. Sometimes this happens over a weekend. You're working on a Friday or a Saturday and no other clinic is open, and then they end up with massive swellings. You're not going to leave them as it is because the insurance is not working. You go ahead and do the treatment. Don't expect that the patient, after the relief of pain, may come back to you, may not come back to you. The insurance gets rejected. The patient might say, the insurance is rejected, doctor, I don't have money to pay. Fair enough, whatever. You have to do your job. You see a swelling, you have to fix that. Get my point? So that is what it means. Providing necessary care even if not financially beneficial. So many times I have done this. I've just helped the patients. I've not expected anything back. But 99% of the patients have come back and finished off the treatment. Even if the insurance has rejected them, they have paid in cash. Barely 1% I remember who I have done the full treatment. The insurance has rejected and the patient is happy. I'm not going back. The treatment is over. It's okay. You did your job well. You don't have that guilt in your heart that because of money you didn't do the work. At least the patient is relieved of the pain. God sees everything. Nothing is absent from the eyes of the God. You do your job. And the last question for today. A dentist lies about experience in implant surgery to attract patients. This violates what? Now, this is very wrong. You should not lie about your competence or the skills that you have, because when the patient will come, he'll trust your words. So, what is it violating? Non-maleficence, which is do no harm, autonomy, that's independence, justice, or veracity. What is veracity? Veracity refers to truthfulness. Misleading patients is unethical. So, if you're advertising something or telling them something which you're not, and not being truthful, you should not lie. That is what it means. That's veracity. Non-maleficence, we discussed that in the previous video, right? It's to do no harm. Autonomy is respecting the patient's decision. They want to go with the treatment, they don't want to go with the treatment. Justice means providing fair treatment to everybody, regardless of their race, caste, appearance, or whatever. All patients are the same for you. So, I hope this is clear. I know you people are learning some new terms here. These are the not common English terms that you use in day-to-day communication language. But it's good that you're learning. and you should imbibe this, and you should teach your colleagues, your juniors. Be the change you want to see. So I hope the voice is clear, my mic is working, and if you want to have this book, just email me on adcwrittenmocktest@gmail.com, and we'll continue to shoot more videos. Have a nice day.